Dear young scientists, with this grace I brought you today, I would like to raise your attention to an incompletely understood and underdiagnosed phenomenon, pseudohyperkalemia. It is underdiagnosed despite the potentially serious consequences of its misidentification. Failure to recognize these spurious laboratory results can lead to overtreatment of hyperkalemia and can be detrimental to patients and should thus be promptly averted. The presentation contains a short introduction, then the case presentation itself after the discussion, and then finally a take-home message. Hyperkalemia is a well-recognized and common electrolyte abnormality. Its prevalence worldwide is around 6%. Excessive potassium intake, also the movement of potassium from the intracellular fluid to the extracellular fluid, and also the decreased potassium excretion can cause hyperkalemia. On the picture on the right-hand side, you can see the symptoms of hyperkalemia, such as heart palpitations, chest pain, abdominal pain, nausea, and vomiting. The phenomenon of pseudohyperkalemia, however, was first described in 1955 as an in vitro phenomenon, and it's characterized by the lack of signs and symptoms of true hyperkalemia, such as ECG changes, along with no response to common treatments of hyperkalemia. It was said at that time that pseudohyperkalemia is the abnormal accumulation of potassium in blood as of its release from cells during in vitro clotting, and also cell destroying over time within the standard collecting specimen tubes. This gives the false impression of raised potassium on laboratory serum measurements. Pseudohyperkalemia is defined when the serum potassium exceeds the plasma potassium value by more than 0.4 millimole per liter, provided that the samples are collected under strict techniques, remain at room temperature, and they are tested within 1 hour from blood specimen collection. Pseudohyperkalemia is positively correlated to thrombocytosis, erythrocytosis, leukocytosis, and the presence of activated platelets, because they are capable of activation at a higher speed and release more potassium during the degranulation phase. The case report that follows aims to raise clinical awareness of this condition so that it may be anticipated and recognized early. The patient is a 41-year-old female who had a neuroendocrine tumor in her pancreas head in 2014. She was operated on and now she lives cancer-free. In 2019, she had severe anemia and received multiple transfusions, but the source of bleeding was not detected. 2 years later, in December of 2021, a Forest type 1b ulcer was detected in her small intestine. 5 months later, she had to be admitted to the ICU and she had to have an urgent surgery because of severe gastrointestinal bleeding. They found a large coagulum and red blood in the area of the pancreatico-jejunostomy and also polyps in her small intestine as a source of bleeding. And the surgeons decided to perform pancreatectomy and splenectomy on this patient. At the end of that year, in December 2022, the oncology control revealed elevated potassium since the surgery, and they recommended nephrology and hematology consult. 5 months later, in April 2023, the hematology consult was carried out in our hospital where I work, and they revealed the diagnosis of pseudohyperkalemia. After that, the patient showed up twice in our hospital. Her diabetes was taken care of in the summer and also in the autumn. This table shows the platelet and the potassium values of the patient in 20 different blood draws that happened after the splenectomy between June 2022 and April 2023. She had lab tests in 3 different hospitals from 4 different departments, and no one, neither the lab personnel nor the clinicians in 10 months thought of the diagnosis of pseudohyperkalemia. Then she was referred to the hematologist at our hospital, who asked for potassium measurement, both from serum and from plasma. Now I would like to show you the 2 lab reports that prove the diagnosis of pseudohyperkalemia. First, we received a serum sample where we measured an elevated potassium value of 5.8 millimole per liter with an elevated platelet count. We commented on the lab report that the serum potassium cannot be assessed due to high platelet count. Please retake the sample in lithium heparin tube. And we also consulted the hematologist on the phone over the phone about this case. After that, so half an hour later, she sent us a plasma sample where we measured the potassium again with the value of 4.70 millimole per liter. That is a normal potassium value. Generally saying, pseudohyperkalemia is characterized by an elevated serum potassium level alongside a normal plasma potassium level. As such, it is diagnosed when the difference between the serum and the plasma potassium is greater than 0.4 millimole per liter in the presence of raised serum potassium levels. From the serum, we measured 5.8 millimole per liter, and from the plasma, we measured 4.70 millimole per liter. So the difference between the potassium values is 1.1 millimole per liter. That is much more than the 0.4 millimole per liter, which is the threshold for the diagnosis of pseudohyperkalemia. The hematologist recommends to measure the patient's potassium level from lithium heparin tube from now on. Before getting to the diagnosis of pseudohyperkalemia, it is crucial to discover the underlying cause of hyperkalemia, as the treatment required for each culprit is different. Treating the wrong cause could be detrimental to the patient. Impaired renal excretion, some drugs, and also insulin deficiency can cause hyperkalemia. As the patient had unremarkable urea, creatinine, and eGFR values, the hematologist could exclude the diagnosis of impaired renal excretion. Some drugs, such as potassium-sparing diuretics, NSAIDs, ACE inhibitors, angiotensin receptor blockers, and immunosuppressants can all cause hyperkalemia. However, the patient's drug regimen included none of the above-mentioned drugs. The patient developed diabetes mellitus after the pancreatectomy. And we all know that a poorly followed insulin treatment, as we know that the insulin shifts the potassium intracellularly through the GLUT4 transporter, and also the hyperglycemia-induced hyperosmolality could promote the potassium shifts out of cell. But the patient had an insulin pump, so that's why her insulin treatment was strictly followed, and the hematologist could exclude the insulin deficiency as the underlying cause of hyperkalemia. Thereafter, the hematologist thought of the diagnosis of pseudohyperkalemia, that is the release of potassium from platelets during in vitro clotting within the standard collecting specimen tubes. Generally saying, 100 giga per liter platelet elevation causes 0.15 millimole per liter potassium elevation. The most common cause of pseudohyperkalemia is cell lysis. Some factors can cause cell lysis, such as mechanical factors. For example, if the tourniquet is applied for more than 1 minute, or the venipuncture is traumatic. For example, the needle they used is with inappropriate diameter, or maybe if the sample is sent to the lab using the pneumatic tube transport. Also, a temperature could be a factor for causing pseudohyperkalemia. It is recommended for storage of the specimen that they used room temperature, because the cold temperature inhibits the sodium-potassium pump, resulting in leakage of the potassium. Also, delayed sample processing can contribute to pseudohyperkalemia, since the ATP fuels the sodium-potassium pump and also maintains the gradient across the cell membrane. We have to talk about the patient factors. Thrombocytosis results in increased release of potassium during the clotting process. As the spleen is a major reserve for platelets, post-splenectomy status has also been reported to be associated with hyperkalemia. Therefore, hyperkalemia without any related clinical symptoms or obvious risk factors strongly raises the suspicion of pseudohyperkalemia. The diagnosis of pseudohyperkalemia is two sizes. On the one hand, the laboratory specialist should suspect it based on the lab report. In our lab, we use a general validation rule based on the literature. So if the platelet count is more than 600 giga per liter, we put a comment on the lab report that the serum potassium cannot be assessed due to high platelet count. Please retake the sample in lithium heparin tube. On the other hand, this platelet count is not necessarily 600 giga per liter, and according to the practice, this cutoff can be lower. So the clinicians must have a high index of suspicion when the measured potassium is high or sharply discordant from the prior readings, or when the laboratory values are not concordant with the clinical pictures. They should take both serum and the plasma sample for the potassium measurement. In conclusion, the safest decision would be if the potassium measurement was performed from a plasma or heparinized whole blood sample. Pseudohyperkalemia must be served as a remarkable clinical condition, and every clinical practitioner must be aware of this phenomenon to have better clinical management. And finally, I would like to thank every young scientist sitting in front of Zoom for their participation in this clinical case discussion session, and also many, many thanks to the IFCC Task for Young Scientists for organizing this event.